Good morning to all of you. Let's learn about actinomycosis today. Why I am teaching you only this topic is this is a slide which you will be seeing. We'll show you the microscopic slides, a slide which is given to you for discussion. Then one of the short essay or short answer topic. And you're going to learn about this even in microbiology, and you need to have this knowledge when you read surgery also. And we being in a tropical country, we definitely keep seeing cases of actinomycosis. Okay, let us define what is actinomycosis. So actinomycosis is a chronic suppurative granulomatous infectious disease. Sorry for that notification. Actinomycosis is a chronic suppurative granulomatous infectious disease. Are you seeing some terminologies which are overlapping? What have we taught you in inflammation? So chronic, acute. So when we say chronic, it is of a longer duration. When we say suppurative, we have learned it is acute. Okay. So acute inflammation is the one which shows presence of pus. Here we say chronic suppurative granulomatous infectious disease. Just recollect what you have learned. What is a cell very characteristic of chronic inflammation? Lymphocytes. What is a cell characteristic of acute inflammation? Neutrophils. But we have told you repeatedly that every rule has an exception. Like for chronic inflammation, though lymphocytes are the characteristic cells, one exception is actinomycosis. Though actinomycosis is a chronic suppurative disease, it shows presence of chronic inflammatory disease, it shows presence of neutrophils. That's why we call it as chronic suppurative. What are the other examples? Any other acute inflammatory process which can have lymphocytes? Viral meningitis. Okay. Though it is acute, when we look at the CSF, what do we see? Lymphocytes. Then, what are the ulcers? What bacterial ulcer can you think of in the small intestine apart from tuberculosis? Typhoid ulcers. Though it is acute, microscopically we see macrophages, like mononuclear cells. Okay. So I'll come back to the definition again. Actinomycosis is a chronic suppurative granulomatous infectious disease caused by what is organism? Actinomycetes. What is it? It's anaerobic filamentous bacteria. Why? The terminology, when you look at actinomycosis, what comes to your mind? Mycosis means fungal infection, right? I'll tell you why. Because this is a filamentous bacteria. Looking at the filaments, this organism was thought to be a fungus. Now we know that this terminology is a misnomer. Okay, and the disease is characterized by swelling, pain, and draining sinuses that discharge actinomycotic grains. I'll show you some gross pictures also. So we call them as sulfur granules. Those who are posted or who have finished surgery postings, I am sure at least you would have seen this. So this was previously thought to be a fungus because they possess branching filaments, which was thought to be a mycelial network, now classified as a bacteria. And the cell wall of these contains muramic acid. So it is susceptible to antibacterial, it is antibiotics. So this is how the organism appears. But why I have taken this picture is just for you to identify the cells which are there, which are here. This is the organism. and all these are neutrophils. So they don't have a very nice round nucleus you can make out. Maybe other pictures are better probably. Here you can make out the lobated nucleus. Lymphocyte would have appeared like this, but all these cells have this only to show that they are the neutrophils that are present around the organism. Yes. Coming to the epidemiology, where do we see this disease? Should we be bothered about this disease? Yes, it's seen worldwide, but most commonly in tropical regions such as Asia, Africa, Central and South America. So it's seen frequently in India in our population. So you definitely encounter a few cases of actinomycosis before you complete your MBBS. Males are more commonly or frequently affected, and how they get infected. We keep seeing a lot of tonsillectomies. Even you see the procedure and the tonsils grossly in ENT, right? So when we examine all these tonsillectomy specimens, most of them show actinomycotic colonies in the tonsillar crypts. That means their commensals there. So sulfur granules, that is the organisms, are commonly found in the tonsillar crypts of healthy people, healthy individuals. And they're ordinarily of low pathogenicity. They do not cause infection, but we call this as an opportunistic infection. So we'll be waiting for an opportunity to cause disease unless there is a predisposing factor, so it does not cause disease. The causative organism most commonly is Actinomyces israeli. The other species are Actinomyces neslundi, viscosus, propionica, odontolyticus and Actinomyces bovis. So Actinomyces neslundi, Actinomyces viscosus, Actinomyces propionica, Actinomyces odontolyticus and Actinomyces bovis. So but remember, the most common is Actinomyces israeli. So they are gram-positive filaments. If we have to know the measurement of the organism, so they just have 0.2 to 0.3 microns width, but they are 4 microns in length. In the tissues, they appear as yellow round grains, but what is the size? That is 100 to 300 microns. So imagine what could be the size. So an RBC is 7 microns. So how many RBCs can you place there? About 40? More than that, yes. So that would be the size of the organism. And these are anaerobic saprophytes and part of normal flora of the oral cavity. Not just oral cavity or the tonsillar crypts, they may be present in the intestine and vagina also. This, I told you, has a worldwide distribution, common in rural areas, agricultural workers and young males, probably because they work more or whatever. So mode of infection. One thing you have learnt is they're opportunistic. Then endogenous in origin. That is, from the mouth, the organisms are aspirated. They may be aspirated into the lungs or they can be swallowed. But rare case reports I've seen where the primary lesion has developed after human bite. So on the hand we have seen following bite. That is how it is transferred from the oral cavity or whatever is there from the crypts. If it has come out, then it is transmitted through the injurious site of injury on the hand following bite. So predisposing factors. Somebody has dental caries or they undergo tooth extraction, very bad oral hygiene, some injury. It could be iatrogenic or due to some other cause, whatever be the trauma there. More than that, trauma on the extremities. Then some chronic inflammation. Then for abdominal surgery, or women with neglected intrauterine contraceptive device. So this device may form a nidus for active growth of the organisms, the bacteria. So based on the anatomic site of lesion, there are 4 main clinical forms that are recognized. One is cervicofacial. This typically presents as a lumpy jaw. It could be a very vague question sometimes, lumpy jaw. Just remember to write actinomycosis. 65% is cervicofacial. Thoracic is 15%. Abdominal is 20%, and next is generalized, which is quite rare. So let's learn about cervicofacial actinomycosis. I told you this is the commonest form, and soft tissues at the angle of the jaw. A patient presents with a swelling with suppuration, multiple abscesses. So swelling suppurates and the abscess ruptures, so that leads to multiple sinus tracts. When you look at this lesion, you can see some yellowish material coming. What is that yellowish material? It could be pus, but still it has definite color of sulfur in that yellowish color. In overlying skin, when we see, it is indurated, very hard, and presents as woody swelling at the angle of the mandible. This is cervicofacial actinomycosis. What are the other swellings? Anything related to the lymph node? African children, if it's Burkitt's lymphoma, yes. See, these are abscesses. They've burst, leading to a sinus tract. See, multiple sinuses, discharging sinuses. This looks like pus, right? So again, this probably is not properly seen, but you can look at the nodular lesions which are ulcerated and formed sinuses which are discharging some material. See how it is at the different stages. There's a lot of fibrosis here, so looks like puckered skin also there. Yes. So next site is the thoracic actinomycosis. So what is affected in thoracic actinomycosis? It is the lungs and the pleura. So from there, where can it spread? From the lungs and pleura, the inflammation can go to the pericardium and the chest wall. So similar features, like even here we see multiple abscesses with discharging sinuses. So these abscesses are seen at the base of the lung also. Third site is abdominal actinomycosis. So lesion here is usually around the cecum with involvement of surrounding tissue. What are the surrounding tissues? Appendix, abdominal wall. We have seen, I think, 2-3 cases of this abdominal actinomycosis. And from here the infection may spread to the liver. How does it spread to liver? Via portal vein. It becomes generalized, right? So generalized actinomycosis is the fourth one. That is due to hematogenous spread from any of the forms. What are the forms we described? Cervicofacial, thoracic, abdominal. Sometimes we say pelvic actinomycosis also. Then generalized. See, there's something special here. You can see the hand involved. I was telling you only following bite, right? So this is punch actinomycosis. What is that? You give a punch. So hand wound caused by hitting somebody or an assailant on their teeth. So it causes injury plus gives a gift of the organisms. That is punch actinomycosis. So look at this picture, self-explanatory. So thoracic actinomycosis, cervical cervicofacial, abdominal, and even the pelvic organs are shown here. No. Grossly, how will it be when we look at the lesions? Let it be anywhere when it is visible to us in the cervicofacial region or on the extremities, whatever. The skin shows multiple small abscesses. Here you can see one. No? See, these are all nodules or abscesses and they have ruptured. So that's what we are seeing, sinuses. Here there is one sinus. It's got some content which is coming out also. This is typically the sulfur granules. Discharging. So some discharging sinuses discharge pus or contain some pinhead sized yellowish structures, that is sulfur granules. And what's happened to the in between skin? So there are a lot of edema here, and when we feel this, we know it is quite firm. That means the skin is indurated, and here it is bluish. Microscopy. So what is the mode of diagnosis now? So when we look at such lesions clinically, yes, the clinician can make a diagnosis of actinomycosis, but how does he proceed for getting a definitive diagnosis? So the sulfur granules can be removed, they can be crushed between two slides and then examined under microscopy with a stain, with a gram stain, all that. Or that material could be taken with aseptic precautions, sent for culture. Otherwise, a part of the tissue can be biopsied and sent to us. So the biopsy tissue material, what do we see? How do we diagnose this condition? So we look at the organism. We see the organism that is present. We say it is bacteria. How is it saying? I told you they're all in colonies. So when they're together, they're about the size up to 300 microns, I told you. So see, these are the organisms. We can make out this actinomycotic colonies, which are oval or round or slightly irregular, typical bluish structure. Okay, these are the filaments. They've all come together and they're all surrounded by what? Acute inflammatory cells. So we can say, when we look at this microscopy, it looks like a microabscess, that is collection of plenty of neutrophils, and in the midst you see the hero lying there. What is it? The organism, actinomycotic colony. This is what you are seeing here, the actinomycotic colony here, surrounded by inflammatory cells. What inflammatory cells? Neutrophils. So I'll make you draw this diagram in the practical hall. So as I draw, you can just draw and then learn. See, this is the surrounding tissue, which is showing fibrosis, congested blood vessels, and lot of other inflammatory cells also. Sometimes there could be, see, macrophages, sometimes there could be giant cells, but this is a typical organism of actinomycosis. And peripherally we see club shaped structures. So these are all filaments. Can you make out two colors? This is blue, this is slightly pink, right? So these are the tangled mass of branching filaments. Then these are all neutrophils. Yeah, I told you two colors you can make out. So bluish. So these are the filaments, tangled filaments, and surrounded by pink. It looks like a border, right? The organism has got a border. This we can appreciate very well in the slides that we show you. So this is called as Splendore-Hoeppli material. This is supposed to be the antigen-antibody reaction or the complex. So these are the the radiating clubs, which are pinkish in color. So this is called as Splendore-Hoeppli phenomenon or the material. Please remember this, Splendore-Hoeppli material or Splendore-Hoeppli phenomenon. So colonies are round to oval or irregular, I told you. So they stain deep blue. Color is important. This is deep blue with the, of course, H&E stain only, bordered by eosinophilic club-like material that represents Splendore-Hoeppli phenomenon. Okay. This is a nice diagrammatic representation. Filamentous bacteria here, club-shaped structure surrounding, and lot of pus cells. This is what you are going to draw in the record, and occasional giant cells could be there. This is a surrounding tissue which can show fibrosis in the later stages, foreign body type of giant cells. There may be epithelioid cells also. So fibrosin granulation tissues. The colony is surrounded by neutrophils, multinucleated giant cells, then epithelioid cells may be there, or macrophages, and then fibrosis. Very easily you can diagnose this condition. So if you just look at the slide grossly, just hold the slide and see, you can make out bluish dots in gross itself. Of course, we give you a proper history also. Based on the history, when you look at the slides, you can make out the diagnosis and identify the organism. So this is in H&E. There are two colors, pink and blue. Blue in the center and pink at the periphery. So this other special stains could be done to demonstrate these organisms. So one is PAS, where they take up magenta color. Then GMS transfer, Gomery's methylamine silver. The organism looks black in color. This is of course gram stain, which microbiology people do, showing gram positive. So all these the cells, what are all these cells? Please have a look at these cells. Can you make out the lobated nucleus? If you cannot make out lobes properly, I am sure they don't have just round nucleus, ant-like we say. So all these are neutrophils. So this is a microabscess. When we microscopically see in H&E sections, lot of neutrophils aggregated together, we say there is microabscess. And in the science, whenever there is microabscess, we carefully search for the organism or what has caused the microabscess. So here we see the bacterial colony which is lying in the microabscess. Sometimes when we study the sections, initially we may get only the microabscess, but clinician would have made a diagnosis of actinomycosis, and when we look at this, we get to know that yeah, this could be actinomycosis. We study more sections so that somewhere we catch the organism, even if it is very small. So we try to catch the organism by searching for it. Yeah. So these are the special stains. So the gram-positive filaments I told you, showed there. Then they are non-acid fast. If you do acid fast stain, they do not take up that magenta color. Then silver stains, yes, Gomery's methylamine silver. Whatever silver stain we talk of, so the end product would be black in color. See, black filaments. This I already told you. So if there are sulfur granules, please pick them up, send them to the department, or just crush and do a gram stain. So the filaments are gram positive. So biopsy, take a tissue, send it in formalin for histopathology, or take that material and ask the microbiologist how it has to be sent. They use thioglycolate liquid medium for culturing this. Or in histopathology, if we still want to do a special stain, there are so many, but we can resort to doing a silver stain, that is Gomery's methylamine silver, or pyridic acid Schiff stain. Then sputum examination in thoracic or generalized cases could be done. So culture, it is supposed to look like a molar tooth appearance. No? Yes. So this is microscopic view of sulfur granules. This is a smear and this is exudate from abdominal wall. After knowing all this, we should know what should be the treatment, right? Once we say bacteria, is it difficult to treat? No, most cases respond to streptomycin or sulfonamides or pyrimethamine and even rifampicin. So it is good. So once it is diagnosed, then treatment is easy. Okay, they respond to therapy. Not I don't think I should say treatment is easy. They respond to antibiotics. Okay, this is about actinomycosis. Remember the morphology. So let us draw a nice diagram of this in your practical class. On Google Meet, I'll take a live class. Then before I end this topic, you need to know about some other terminology here that is called as mycetoma. What is mycetoma? Oma, we have taught you. Oma, if the suffix oma is there, that means it's a tumor. But this is a misnomer here. It's a tumor-like lesion, mycetoma. Okay, this is again a short answer or short essay topic for you. Please listen carefully. At least register few important points related to this. What is mycetoma? It's a localized chronic granulomatous infection of subcutaneous and deeper tissues of foot and sometimes hands. So actinomycosis, we said 4 different forms. So here this is localized. See, one terminology, localized, it remains. Chronic granulomatous, not acute one, it's a chronic process. What does it affect? Where is it infected? What tissues are infected? Sorry. So subcutaneous and deeper tissues. Which organ, which place? So foot, most common, and then sometimes hands. So this presents as a mass or tumors. That's why called as mycetoma. What is the characteristic feature? Just like actinomycosis, even this has multiple discharging sinuses. Cause either fungus or bacteria. So if mycetoma is caused by fungus, we call it as fungal mycetoma. If it's caused by bacteria, we call it as bacterial mycetoma. But if it's bacterial mycetoma, it responds very well to treatment. Fungal mycetomas are common again in tropical countries, especially in our country. And of course, in my tenure, I have seen many of these. We have mounted also these specimens in the museum, you can see. So fungal mycetomas are common and they are referred to as madura foot. Heard of Madurai? Know that place? Madurai Meenakshi. So we visit that temple, right? Tamil Nadu. This was first described from Madurai by Gill in 1842. That's why they called it as Madura foot. So the topic, short note topic could be mycetoma or Madura foot. Both are same, you are writing the same thing what I am discussing now. See, look at this. Foot is affected and the lesion has gone above the ankle also. How can you describe this? The foot is swollen edematous. What do we see on the surface of the skin? Multiple nodules. See, multiple nodules. What's happened to the skin covering the nodules? No, they're ulcerated at many places. They're discharging something. So, the color, it's somewhat orange here. It's not just blood. Then what has happened to the skin in between? It is indurated. This typical description of Madura foot. Common in tropical countries and fungal Madura foot caused by fungus. There are more than 13 species of fungi, you should remember. But remember 2 common organisms. Madurella mycetoma and Madurella grigia. Madurella mycetomi and Madurella grigia. We see lot of different colored fungi in the biopsies. But how does man get this infection? All these organisms live in soil. So, introduced into the skin or the subcutaneous tissue following injury. So, who are the people who are prone? Farmers, or people in rural area, people who walk barefoot, agriculturists and all that. So, foot is the common side because the organism is in the soil. And when this organism enters into the body, it usually, the lesion starts as a papule. A small nodule is a papule. Then it increases in size. We call it as a nodule. So in spite of the nodule being formed, it will not be painful. So patients may not come to the attention of the doctor, or they do not seek advice from the doctor. So painless nodule at the site of injury. Slowly this painless nodule suppurates. So we see collection of pus, and with pus what happens, the tissue is soft, it becomes soft, and skin would be stretched. So ruptures. Once it ruptures, what does it produce? It produces sinus. And what comes out through the sinus? Pus is one thing, plus what is a causative organism that is there inside. So the fungal colonies start coming up. So it could be blackish material being discharged. It could be yellowish, depending on what is the organism that is there inside, which fungus it is. And similar to like exactly how I described. So we see nodules on the skin, discharging sinuses, edema, the affected part is swollen and skin is indurated. Look at this picture, very typical of mycetoma, but we have to decide, take a biopsy of the lesion and then decide, get a definitive diagnosis as to whether it is actinomycosis or fungal. If it's actinomycosis, then feel happy, tell the patient that yeah, your limb is saved. If it is fungal infection, you can't do anything, amputation has to be done. So bacterial mycetoma is caused by actinomycetes and nocardia. Nocardia is another organism that causes this madura foot, but we have to differentiate between fungal and bacterial mycetoma. Sometimes we talk about actinomycetoma, that is, it's a form of madura foot or mycetoma caused by nocardia species. Okay, so actinomycosis of an extremity and actinomycetoma can produce virtually the same disease characteristics. I told you, grossly we cannot differentiate, biopsy is a must. So sometimes this can involve the underlying bone causing osteomyelitis, also localized chronic and progressive infection with purulent sinus tract draining with that sinuses, you can say, which drain or which contain granules which are of different colors, but here with actinomycosis it will be yellowish, and that involves the adjacent. It may involve adjacent bone also causing chronic osteomyelitis. So actinomycetes has two genera, Actinomyces and Nocardia. So Nocardia, they are named after Edmund Nocard. They are aerobic, they are gram positive, catalase positive, rod shaped bacteria. They are partially acid fast. I told you Actinomyces is not acid fast, but this is partially acid fast. This helps us to differentiate between the two colonies whenever we have a doubt. What is the color of Actinomyces? Colony of Actinomyces, it's bluish, whereas Nocardia will be pale pink in color. So this is just the difference. I don't think you need to know about this. So this is about actinomycosis. I have taught you in brief. about this lesion. Okay, listen to it again, learn about it. So once you listen, you're familiar with the topic. So read it, go back and open the books and read. Then it is like reading again, reviewing. So it goes into the long-term memory, and I don't think before the exam, the previous day, you need to read about it again. So make this as your final reading and then keep on reviewing, recollecting, so that it remains in your memory. Okay. Thank you.